session number 2, Photoreceptors and AI in AMD. My co-moderator, Jacqueline Kovac and Phil Rosenfeld. And without further ado, I would like to invite our first speaker, Srinivas Vasada, to speak about validation of photoreceptors metrics for AMD using adaptive optics SLO. Go ahead, Vas.
Thank you very much. These are my disclosures, and these are my take-home messages. RPE-adjacent deposits in AMD can pose challenges for EZ-based metrics. Direct visualization of the photoreceptors using AO may provide a more objective assessment of the accuracy of the various different photoreceptor-based metrics, and outer nuclear layer-derived measures may provide a more complete and sensitive assessment of the status of the photoreceptors and may be an option for future studies. Now, there are many potential options for assessing the status of the photoreceptors, ranging from the outer nuclear layer as well as the EZ and other structures as shown here, as well as combinations such as the outer nuclear layer plus Henle's fiber layer. But at the same time, we need to recognize that EZ has really come to the forefront, in part because it's obviously quite well visualized and we know that it can correlate with function. It's also proven to be successful as an endpoint for FDA approval, as we observed in the revakinagene trials, where EZ area loss was useful for demonstrating the benefit of the therapy. I do want to highlight, though, that MACTEL really represents the ideal scenario for EZ assessment because of the relatively flat topography of the disease. This is not the case in AMD, where the EZ may not be so easy because of the fact that you have lesions like drusen that alter the topography, and we know that the reflectivity of photoreceptor-related bands can be impacted by the angle of incidence as well as the overall scan quality. Now, there have been solutions such as directional OCT that have been proposed, but this is probably not really practical in the context of large multi-center trials. So, another complication is that there is variability in how we actually approach and quantify the EZ. Now, the simplest way, which is what's done in a lot of IRD studies, is to simply segment just the EZ band alone. And then you can produce an area on an en-face imaging, and this is the kind of thing that was done in the MACTEL type of studies. But in most AMD trials, most investigators actually segment two bands, both the EZ as well as the RPE, and measure the thickness between these bands. And then when the thickness falls below a certain threshold, they consider the EZ to be attenuated. Sometimes people call this the EZ thickness, although it's really the outer segment thickness that we're talking about. Now, unfortunately, there's a lot of variability in how this is done by these various automated algorithms and even with semi-automated approaches because we don't have a consensus as to where exactly the boundary should be positioned. There's other problems as well because you can have AMD-associated deposits such as subretinal drusenoid deposits, also known as reticular pseudodrusen, which can impact these measurements. Let me show an example. For example, if you measure the EZ between the EZ band itself and the RPE, then your EZ thickness measurement will necessarily include the STD, and of course it'll be quite different from a true outer segment thickness measurement. This is something we presented at ARVO, and certainly in areas of predominant STD, there really is no correlation between EZ thickness and outer segment thickness in this instance. And so because we don't have this consensus and we don't really know what these different algorithms are doing, I'm really pleased that Omer Tversky and Phil Rosenfeld, through the International Retinal Imaging Society, have established this algorithm validation committee so we can get a consensus ground truth from multiple reading centers and then have a way of really evaluating the performance of different algorithms. So we look forward to that in the future. But I want to say that there are more concerns, and that's what really I would like to focus on. We know, for example, that having an intact EZ does not necessarily mean the photoreceptor is intact. You might need to consider the reflectivity as well, as we've shown with AO. In addition, with AO, we've seen that one can appreciate a progressive loss of the photoreceptors even in the setting of an intact EZ, again looking at the photoreceptors assessed by adaptive optics imaging. And this is actually, I think it makes a lot of sense to me. We know that in the outer nuclear layer, the photoreceptor nuclei kind of spread out, but they all have to funnel in to the EZ. So the outer nuclear you might think might be more sensitive. And I think this case from Frank Holtz really illustrates that, where you can appreciate a thinning of the outer nuclear layer here, even though the EZ thickness doesn't really change very much. So this really raises the point that maybe the EZ alone is not enough. There may be other photoreceptors metrics that we might need to consider, but the question is, how do we choose them? How do we validate this? And this is where we thought direct photoreceptor imaging with adaptive optics could help. So the purpose of the study I'm going to show is to really investigate the correlation between cone photoreceptor density and the thickness of these various outer retinal layers on OCT, specifically looking at unremarkable areas in eyes with intermediate AMD. So we went to our database of patients we had AO imaging on who had intermediate AMD, and then we looked specifically at cases that had multiple visits and had good quality AO and OCT images so we could do this kind of assessment. Now, we focused specifically on OCT and adaptive optics, but we did do multimodal imaging on these subjects. This is an example of a montage of different AO images obtained over time, laid on top of the color photographs. We could use the vessel landmarks to register the color images and then registers to the IR image and the OCTs as well. And we specifically focused on regions of interest where there were no AMD lesions, such as STD or drusen. This is an example of the tiny grids that we use, 40 micron by 40 micron squares, in which we did the photoreceptor counts, and that constituted the region of interest where we looked for unremarkable areas. Then we used a commercial segmentation algorithm for Retina AI to segment the EZ thickness. They call it the EZ plus OPR plus IZ complex. We also segmented the MZ, or the photoreceptor inner segment thickness, and also this combined outer nuclear and Henle's fiber layer thickness. Then we computed the mean thickness within those little tiny regions of interest so we can correlate them against the cone counts, again specifically focusing on areas that were clinically unremarkable. Here's an example of a segment where we had AO imaging, and you can see between the yellow arrows is the unremarkable area, no drusen or STD there. Here's a higher power view looking at the AO images. Again, we did the cone counts in these areas, these regions of interest. And this is sort of a summary of the cohort. There were 10 eyes with a longitudinal follow-up of over 40 months, as you can see here. And we studied over 850 regions of interest and multiple visits across this cohort. And the cone density, regardless of the region you looked at, we looked at different eccentricities because we know the cones are easier to count the further away from the fovea you get, but the cone density declined in all of the different zones. But this is really the money slide. When we looked at the correlation against the layer thicknesses at baseline, the cone density really only showed a significant correlation with the ONL plus HFL thickness. Notice EZ thickness did not correlate. We also looked at follow-up. Here again, the strongest correlation was the outer nuclear thickness. The EZ thickness did not correlate with the cone density counts. There was a correlation with the inner segment thickness, although when we did a sensitivity analysis looking at more distant regions where, again, the cones are even better visualized, again, only the outer nuclear layer actually showed this correlation. So to summarize, RP-adjacent deposits associated with AMD can pose challenges for EZ-based metrics. Direct visualization of the photoreceptors with AO may provide us a way to better assess the accuracy of various photoreceptor-based metrics, and the outer nuclear-derived measures, in particular this ONL plus HFL thickness, it may provide a more complete and sensitive assessment of photoreceptor status. And I think it could be a very valuable addition to future studies, and notably I want to highlight that EZ thickness did not correlate with AO-SLO measured cone density. Thanks very much.
Super interesting, Vas. I have another money question. So did you check any functional output with that as well, like correlation with what you found? Because, the stress of EZ that we have is the fact that it's correlated with function, and that's what, the regulation is so care about.
Yeah, no, that's a very important point, Omer. And no, we have not so far. We are looking forward to using AO microperimetry to do a very careful interrogation of these regions for function as well. But I completely agree that will be a critical assessment to have as an additional correlation.
Maybe it will solve all our problems, which we have.
I don't know about that, but hopefully we'll gain some further insight into structure function correlation.
Omer, I got a question.
Yeah,
So
sure.
Vas, this is fabulous data. And one of the reasons why I really like it is that it's much easier to develop an algorithm for the outer nuclear layer, Henle's layer, than it is to reproducibly develop an algorithm for the EZ. Have you looked at any of the existing algorithms to see how well it can be quantified?
Yeah, no, it's a great question, Phil. We haven't compared different algorithms. I'm hoping that your algorithm validation committee with Omer will look at that as well. I know the focus is on EZ, which is very appropriate given that that's the parameter that we're using. But I do think as maybe as the next exercise would be to look at that because I do agree that that is a potentially easier target. And again, because the dynamic range is going to be bigger, right? Because
Right.
you've got the photoreceptor nuclei spread over a larger distance. And I think that is the benefit of using that as a target for assessing photoreceptors.
And it won't be complicated by reticular pseudodrusen, and maybe the
Exactly.
drusen not as much. Okay.
Right.
Super interesting. Thank you, Bas. So let's continue. We'd like to invite Giovanni Storangi to speak about ellipsoid zone measurement, pros and cons. Giovanni, take it away.
Good morning. First of all, I would like to thank Professor Rosenfeld for the kind invitation at the Angiogenesis meeting 2026. My topic will be ellipsoid zone measurement, pro and con, and these are my disclosures, and the ones in red are the most relevant for my presentation. When we look at the OCTs, we can actually detect many different characteristics for identifying pathologies. But the ones that are most actually used for measurement the effect of some drugs, or the ones that are suggested, are the ellipsoid zone and the outer nuclear layer. In particular, if we look at this paper from Ursula Schmidt-Erfeld's group, using data in a post-hoc analysis of the pegcetacoplan study, they were looking not only at changes in atrophy of the retinal pigment epithelium, but changes in the photoreceptor, just looking at the ellipsoid zone area. In particular, the one that was quite interesting was the fact that the photoreceptor were in the placebo group were fastly disappearing comparing with the retinal pigment epithelium, showing that a better identification of the photoreceptor and the target of those could be much more important for understanding the effect of a new drug. Moreover, the correlation between the photoreceptor and loss and the function was much more correlated. But what are the EZ zone? The ellipsoid zone are characterized by the hyperreflective mitochondria compact in a photoreceptor cells. Meanwhile, the outer nuclear layer, it's characterized by the cell body of the nucleus of the photoreceptors. Now, what can actually interfere with the measurement of ellipsoid zone? First of all, depends on the disease. And here are just a few examples on the left side comparing with the normal subject OCTs, where you actually see that the presence of the ellipsoid zone can be a little bit more difficult in be identified, particularly if you have drusen or you have subretinal drusenoid deposits. In that case, the possibility to identify clearly the presence of the ellipsoid zone could be a little bit more difficult. Here, just another example of the retinal drusenoid deposit. But also depends on the image quality. And now if we look, for example, at a normal patient with disease and with an average of 100 B-scan, you can actually see the presence of the ellipsoid zone, but that could be changing, and also the size can change. And if you are, your hyperopic defocus, or myopic defocus, or you reduce the average to 10 instead of 100. And here it's a little bit more fuzzy and more difficult to identify. And again, if you have then a myopic defocus, you can actually also have a different appearance of the Z and also a different measurement. What about the outer nuclear layer? We know the outer nuclear layer, it's in a normal OCTs can actually visualize all together with the end fiber layer. And we know that only tilting the image and allowing the lights to reflect more on the end fiber layer, we can actually differentiate the outer nuclear layer from the outer plexular or the end fiber layer. And you know that was called and introduced by Lujan as a directional OCTs. The other thing is that in the near future, we will have new devices with higher resolution. This is a prototype from the Professor Fujimoto group. And you can actually see that you can define much more lines, and that could be, in some way a problem. So if we look, for example, at the all OCTs, and we overlap with the higher resolution, in the axial, particularly the axial resolution, you can actually see that, first of all, we can differentiate the outer nuclear layer to the end fiber layer without having the tilting of the image. And also, if you look at the EZ, the size of EZ can be different. So also to compare with a normal subject to a disease subject, the data can be a little bit different. The other thing is that from this paper from Josh Jonas' group is that we can see that the photoreceptor, the outer nuclear layer, the ellipsoid zone, and the photoreceptor are actually decreasing in size with age. And it's more stable, the ellipsoid zone, but more evident for outer nuclear layer. So the thickness decrease also with the longer axial length, the longer disc fovea distance, and may point to an axial elongation associated retinal stretching of the macula. So we have also to consider such things. But is ONL already used in evaluation of data from clinical trials? Again, with the post hoc analysis of the pegcetacoplan, Maximilian Fau and Frank Holt's group, actually evaluated, with the ONL in patient with atrophy and the surrounding area. And they show the possibility to look at the difference between the monthly to the other month injection. So in conclusion, ellipsoid zone and outer nuclear layer are both promising biomarkers. Both are associated with visual acuity changes. Ellipsoid zone, even although approved by FDA as a potential endpoint, present challenges in the accuracy of the measurement, not so much the outer nuclear layer. And even if it's associated with end fiber layer, are more reliable and reproducible in measurement. Outer nuclear layer looks more sensitive to monitor retinal changes because it directly reflects photoreceptor survival, provides a continuous and quantitative measurement, has a larger dynamic range, is less influenced by OCT artifact, and correlates well with the functional outcome in some treatment contexts. Again, thank you for your kind invitation.
Thank you, Giovanni. So I have a question. So with all the limitation you showed us, if you had to design the next clinical trial, where would you put EZ and ONL in your endpoint list, considering the limitations that we have right now?
Well, first of all, I have to say that probably I will use the same OCT device because changing the device, you can actually get the different numbers. If you look at, as we did with CAM, the integrity, probably it's easier to define and you can use any device. But if you want to measure, probably there is a possible artifact due to the different characteristics of the OCTs. Because of that, I would actually probably use more outer nuclear layer than not EZ. And also, I think I'm completely agree with Vas, what Vas said before and what presented. And I think this is just another, support of what we thought about, the ONL measurement comparing with EZ.
Any other questions from the panel before we proceed?
Looks good.
Thank you, Giovanni. Phil?
Thank you.
Okay. So our next speaker, Carl Chaki, will talk about further assessment of cone structure function in non-foveal GA. Take it away, Carl.
Thank you, Phil. Thank you, Harry. Thank you, Tom, for the kind invitation for the meeting. Today I'm going to be talking about further assessments of cone structure function in non-foveal geographic atrophy. These are my disclosures, none of which are relevant, and the disclosures of Dr. Tandon, who worked with me on this project. So the take-home message is anti-complement therapies reduce photoreceptor loss, but it's unclear of the rod versus cone effects. We've demonstrated that center 1 millimeter of macular tissue are most highly correlated with visual acuity, and thus interrogating that center 1 millimeter with a cone-specific microperimetry can teach us something about cone function and cone sensitivities. And so we're ultimately wanting to understand fully this idea of cones at risk. So if we take a step back and look at how we initially convinced the FDA to use a reduction in GA expansion as an endpoint, we really didn't stress this idea of differentiating between cone loss and rod loss. And this has become important because the EMA in particular is focusing on functional outcomes, and it appears that these functional outcomes correlate more highly to cone function. Therefore, understanding what's happening to cones in this disease is going to be critical. Again, the rates of geographic atrophy expansion are reduced with both agents, but it's also important to understand that in many cases, such as this case, over 6 years we can have extensive rod loss, and yet the center 1 millimeter, the cones, are preserved even after 6 years, and this patient continues to have good visual acuity. These results were also published and demonstrated by Ursula when she used AI to understand RPE loss and EZ loss, both in the sham group and the pegcetacoplan group. And again, you can see this extensive rod loss before the cone structures are affected. And in fact, when you look even at the natural history, the initial changes in the center 1 millimeter appear to be not correlated as a direct extension of the loss, but appear de novo, again suggesting that whatever is happening to the cones is distinct from what's happening to the rods. This was also seen when we look at the rates of vision loss. Again, pegcetacoplan had less visual loss than sham groups, but within those groups there are large variabilities, again suggesting that cone loss rates are different between patients. Now, we've been interrogating this concept further by using this concept of macular tissue integrity, looking at the viable amount of macular tissue within the center 1 millimeter. And we've shown that unlike the area of geographic atrophy that does not correlate to baseline visual acuity, the amount of macular tissue you have in that center 1 millimeter, while it's not explaining everything, the R-squared value is 0.21, again explaining that there is some correlation with visual acuity and that center 1 millimeter. But what's most intriguing when you look over a 12-month period at this rate of loss in the center 1 millimeter, those rates are highly disparate. We have patients who lose lots of tissue very quickly and other patients that don't, and that's independent from their baseline degree of loss. Again, understanding what is our predictors of both EZ loss and photoreceptor loss in the center 1 millimeter is still unclear. And in fact, we demonstrated in this paper that there was no correlation between the rates of geographic atrophy and the rates of center 1 millimeter loss. Again, suggesting that cone loss and rod loss are different and highly heterogeneous. So we've been interrogating further the center 1 millimeter with a focal microperimetry. You can see we get lots of sensitivities within the center 1 millimeter, and we can even look at structure functions by using Retina AI. And when we do that, we do see correlations to some degree with mean sensitivities and the average RPE changes. And we also see to some degree similar correlations with EZ, but it's important to recognize that the relationships are not linear. And so we have to use weighted least squares to get some good R-squared values, but again, suggesting that this relationship between cone sensitivities and EZ is not 100% clear. And then finally, when we start to look at the relationships between the mean sensitivity within that center 1 millimeter and other aspects of cone function, we can see that those sensitivities do correlate to other measures of cone function. Low luminance visual acuity, QCSF, and low luminance QCSF all correlate very well to the mean sensitivity, and we did this under very stringent rates of correlation to include the multiplicity of examination. So again, very strong correlations to these cone functions using that center 1 millimeter mean sensitivity, but interestingly, it did not correlate to the visual acuity. So again, we are now in the process of understanding what is it about the center 1 millimeter that correlates to some aspects of visual acuity, and more importantly, can we now start to generate some real aspects of vision function, reading speed, and other aspects that will really impact patients' quality of life, and how interrogating that center 1 millimeter tissue, which is a relatively easy and straightforward step in our studies, is that and will be an important way to assess the effects of therapies on cone function in the future. So, to summarize our take-home points again, anti-complement therapies do reduce photoreceptor loss, but it's unclear what the rod versus cone effect is. The changes in the center 1 millimeter macular tissue are more correlated with visual acuity, and the use of this focal cone-specific microperimetry does correlate with other aspects of cone function, but really what we need to understand more fully is the variability and, more importantly, this concept of cone as risks as we start to understand the effects of therapies on visual function. Thank you very much for your attention.
Thank you, Carl. That was super interesting. So I'm trying to think, how can we take it, forward to our clinical studies? And I wonder, do you think like in the future we'll have to separate between effect on cones and effect on rods when you move forward?
I mean, I think that's going to be an important question, right? Because again, if we look at quality of life, all the measures that we want our patients to have, I think understanding how their cones are functioning is absolutely essential, right? And so when we're seeing that the two rates, and we know this from long times, the rates of degeneration of these two types of photoreceptors are different. So it makes sense that the therapies could be different on a cone versus a rod. So I do think that it's going to be essential as we think about therapies, how cone protective are they or how rod protective are they?
Super interesting. Thank you. And we'll move forward because we're a little bit behind. So our next speaker going to be Amita Domapalli. We're going to speak about the method for assessing photoreceptor loss in GA. Go ahead, Amita.
Hi, I'll be talking to you about methods for assessment of photoreceptor loss in geographic atrophy. I have no financial disclosures. Photoreceptor loss is a key endpoint in GA trials, and loss of ellipsoid zone on OCT is generally considered equivalent to photoreceptor loss. So this inset here shows you the different layers, and the second hyperreflective layer is the EZ. This is a complex measurement, and usually reading centers use AI-based measurements with human oversight to do this assessment. Standardization is important to ensure comparability across studies and algorithms. There are many ways in which EZ loss or photoreceptor loss can be measured. These are some methods. There are others that I haven't listed. And I'll be talking mostly about segmentation and edge detection, which are two methods that we use at the Wisconsin Reading Center. So this is segmentation. Essentially, we all know ILM RPE segmentation is pretty common. So here, the ellipsoid zone is segmented, EZ area, using this blue line, and the pink line shows RPE. So every time the blue and the pink touch, this onphos is generated, so that's zero thickness. Now it's not exactly zero thickness because there is a little bit of a buffer allowed, and that buffer is customizable between various algorithms, whether it's 0, 2, 5, whatever the value used. This is edge detection, and here the ellipsoid zone loss between this edge and this edge is marked using this green line, and this line is transferred onto the onphos map, which generates area assessments. So this only looks at not the entire B scan, but only where the EZ is lost. This example shows segmentation up on top and edge detection at the bottom, and you can see 8.19 is the EZ loss, 8.18, so pretty similar. We can also generate RPE loss measurements using the two methods in the same way, and here you can see 6.6, 6.6 exactly. So we compared the two methods in about 50 eyes with GA, and you can see the mean EZ loss area is a little different between the two, statistically significant, whereas RPE loss is much tighter. In a subset of eyes, 15 eyes, we had change over 1 year, and when we looked at change, the same trend followed. So 1.45, 1.71, they are slightly different. These are Bland-Altman plots showing the same data, and you can see here this is smaller GA, and this is larger, kind of more complex GA. So the differences emerge in the larger GA lesions, and small lesions. Both methods seem to measure the same way. Mean difference in the two methods on EZ loss was about 1.1 with between segmentation and edge detection, and for RPE loss it was minimal, 0.17. Here you can see we looked at different reasons for disagreement. Of course, the reason for the differences is the reason that the two methods are different. Segmentation does the entire B scan, whereas edge detection only focuses on area of GA. So segmentation tends to capture even EZ loss overlying drusen, like here. And this is the area of GA, and edge detection only focuses on GA and it just ignores everything else. So these regions that are captured here are drusen-related easy loss, and they're not picked up by edge detection, which accounts for the differences. This is an example of an eye with a drusen. You can see the easy is absent overlying the drusen, and at 1 year the drusen has dissolved and photoreceptor layer has returned. So this is probably not a true loss. It is kind of because of the way OCT mechanism functions. So here is an example showing 1 year change, and you can see there is quite a bit of this drusen-related easy loss around. The GA-related easy loss has definitely grown in size, enlarged over 1 year, but there's also all this, and that has disappeared at 1 year in this eye. So, you know, it's not there, it's reduced. And this is another example where that drusen-related easy loss has enlarged, and so now this is GA has developed. So all this is not picked up on the edge detection, so it's missed. So it's not missed, it's not even included in the analysis. So if you're looking at precursors of GA, the edge detection might not pick that up. But if you're looking at purely GA-related easy loss, then the edge detection focuses on that better than segmentation. So it all depends on what the endpoint focus is. So we have, here are the differences between the two methods. Segmentation does both partial and complete easy loss, whereas edge detection does only complete loss. The placement of boundary line can vary between algorithms. Calculation of absence can vary between algorithms, whereas edge detection is a little more standardized because it's edge to edge of loss. There's not much you can do with that. Segmentation covers the entire OCT volume, so reviewing each B scan and editing can be time consuming, whereas edge detection is faster because you're only looking at short areas. It does ignore the regions of drusen-related easy loss with edge detection, so that's something to consider. So to conclude, both methods in small GA look very similar results, but in larger complex lesions, the differences are visible, and each method provides complementary advantages. So you need to understand that there are differences in methods, differences in outputs. We need to define reliable ground truth and to get to these endpoints. So more work is needed to standardize easy loss, and I know there's work in progress, so we look forward to all that. I'd like to thank my team for all their hard work in segmenting and taking care of all these data sets. Thank you.
Thank you, Amita. I really liked it. So when I look, it seems like the edge detection is much more intuitive. It's like it's easy to understand. And I wonder, when you compared between your graders, what were the reproducibility of the two different methods between your different graders, if you have any data on that?
Yes, we do have. The publication is under review and will be out soon. But intuitively, yes, the edge detection reproducibility is way better. It's just that the variability in the definition is so little with that. You're just restricted to the GA area, so it is definitely much better than segmentation, where you could miss a couple of spots here and there, and it brings in all the differences.
But average-wise, the numbers were the same between the two.
Yes.
Averagely,
yes, they were pretty similar. But I do think it brought up this important point that, like all the presentations before showed how easy loss in phase 3 trials, maybe it is worth looking at a separate, like GA-related easy loss and non-GA-related easy loss as two change metrics. They may be different. And what is driving the results? Is it the GA or is it the drusen?
Oh, well, great question.
Yeah, do you see using both strategies in evaluating scans? Not just one algorithm, but two?
We haven't so far. This was primarily for comparison purposes. It is a lot more work, but it can be done. That would be great to do both strategies.
Agree. Thank you. We'll move forward with Justice Seller. We're going to talk about the impact of pseudodrusen on ellipsoid zone integrity measures in dry AMD. Take it away, Justice.
Good morning. It's a pleasure to be here. I want to thank Phil, Harry, and Tom for the opportunity to present here at this wonderful meeting. These are my financial disclosures. We are really entering a new frontier in dry AMD therapeutics. With the recent approvals of complement inhibitor therapy in the United States, there's a new focus on identifying key risk factors for progression. One of the major challenges in this space has been identifying endpoints and biomarkers that can be used both clinically as well as that can be approvable for clinical trials. OCT provides a unique opportunity to evaluate specific biomarkers based on underlying structure. Multiple groups have demonstrated numerous different biomarkers, including hyperreflective foci, subretinal drusenoid deposits or pseudodrusen, hypertransmission, EZ loss, and others that have all been linked to progression in dry AMD. Today, we're going to talk about two specific imaging biomarkers and their interplay. The first I want to talk about is quantitative ellipsoid zone integrity. There are multiple different methodologies for evaluating ellipsoid zone integrity. In this analysis, multi-layer segmentation is performed where the ellipsoid zone is identified as well as the RPE. This technique allows for the identification of total ellipsoid zone attenuation or loss, meaning that the ellipsoid zone is completely absent. This is the FDA approvable endpoint that's been noted for dry macular degeneration using OCT. In addition, this methodology allows for the measure of partial ellipsoid zone attenuation or degradation, which is an abnormal thinning of the height between the ellipsoid zone and RPE, measured as 20 microns or less. The mechanism of action of a specific therapeutic may be an important contributor to which biomarker may be most effective to measure, and there might be a critical window for intervention. One of the things that we've found using these techniques in various clinical trials is that ellipsoid zone loss excess provides important critical information for identifying rapid progressors. This was work done by Ursula Schmidt-Erfurth's team, showing that in Derby and Oaks, when the cohorts were evaluated based on their ellipsoid zone to GA difference, or the gap in ellipsoid zone excess, that the highest quartile with the most amount of ellipsoid zone loss excess had a significant increase in GA growth over time. Similar work done in the GATHER1 and GATHER2 clinical trials showed both partial EZ attenuation and total EZ attenuation and EZ loss excess were significantly associated with GA growth speed. What about intermediate AMD? Well, we know from multiple trials now that ellipsoid zone loss appears to play a critical role in progression risk. Just as some examples here, it really appears that not all drusen are created equal and may have a differential effect on the photoreceptors. We see here the drusen map in the second column in green, with showing significant volume of drusen in this macular cube, with minimal effect on the ellipsoid zone, noted here in the third column in green, and overall, over the course of 2 years, minimal signs of progression. Conversely, in this eye, we see similar amounts of drusen volume with a dramatic impact on ellipsoid zone loss and partial EZ attenuation. Over the course of 2 years, this progresses with the development of geographic atrophy. So what about subretinal drusenoid deposits and EZ loss? What is the interplay between these biomarkers? This is something that really hasn't been extensively explored to date. Subretinal drusenoid deposits, or SDDs, are also known as reticular pseudodrusen, are extracellular deposits that form between the RPE and the photoreceptors, and they contain membranous debris resembling lipoprotein particles and collagen-like fibrils, suggesting both a lipid-rich and fibrous component. So the goals of this analysis was to better evaluate the interplay between SDDs and quantitative ellipsoid zone integrity, as this has not been well delineated to date. We're also hoping to evaluate the relative contributions of SDD and ellipsoid zone integrity to disease progression in intermediate AMD. So our key questions were, how does ellipsoid zone integrity measures vary based on the presence or absence of SDDs? And does SDD independently predict progression to geographic atrophy? This was a retrospective image analysis study from 2 centers in eyes with intermediate AMD or GA at baseline with 2-year longitudinal follow-up. Reading center image analysis was performed with 2 independent reads, one for the quantitative ellipsoid zone integrity measures and the second for the presence of SDDs. The focus of this analysis is the intermediate AMD cohort, with those eyes that went on to maintain their intermediate AMD status compared to those eyes that went on to geographic atrophy. In this cross-sectional comparison of those eyes that had SDD present versus those eyes that didn't, we see that when SDDs were present, they were greater in those eyes that progressed to geographic atrophy. And importantly, there was a greater amount of partial EZ attenuation and total EZ attenuation compared to those eyes that did not have SDDs present at all. So what about intermediate AMD progression to geographic atrophy? Overall, when we look at the cross-sectional comparison in this intermediate AMD group, those eyes that were stable, there were 431, demonstrated significantly less SDD incidence, as well as dramatically less partial EZ attenuation and total EZ attenuation. Similarly, there was also decreased hyperreflective foci presence, as well as reduction in hypertransmission present. When we looked at the univariate AUC, all of these features were at a univariate level significant in predicting GA progression. Partial EZ attenuation was the most significant variable, as noted here. And when multivariate assessment was performed, SDD presence was no longer significant, but partial EZ remained significant in the multivariate evaluation. This is a clinical example here of an eye with reticular pseudodrusen and ellipsoid zone loss that's quite extensive at baseline. Over the course of time, we see at month 6 early evidence of geographic atrophy. Month 12, the geographic atrophy continues to grow. Month 18, month 24, month 30, and month 36. Overall, when we look at this predictive pattern, we see that the GA map closely mirrors the ellipsoid zone integrity map from 2 years prior. Overall, in conclusion, SDD does predict GA progression in univariate models, but loses significance with multivariable assessment when ellipsoid zone integrity is considered. Ellipsoid zone integrity remains a significant independent predictor even after adjustment. In addition, ellipsoid zone integrity improves predictive multivariate model performance, whereas SDD does not. This is suggestive that SDD may in fact be a sign of underlying photoreceptor compromise and outer segment degenerative changes. Further work into evaluating the phenotypic variability of ellipsoid zone loss and concurrence of SDD is needed, including an assessment of differences in therapeutic response based on the presence or absence of SDDs. I want to acknowledge my team, in particular my 3 research fellows, Masahiro Mizuno, Karen Matar, and Paula Simoes, who were instrumental in this work.
Thank you, Justice. So I have 2 questions. First one, how do we know that this easy attenuation that we found is not because the directional effect of the OCT we have, which we could not identify the easy on top of SDDs? And the second is, I think we also spoke about it before, how would you take into consideration patient with SDD in future clinical trials based on what you found?
Yeah, thanks, Omar. Those are great questions. One of the key things, Vas talked about directional OCT. Brandon Lujan has talked a lot about this. And in many of the papers, when we look at the directional effect, we predominantly see a significant reduction in the intensity of the EZ band and not necessarily a complete disappearance. So when we think about a measurement where we're looking at total loss or, for example, a thinning between the band and the RPE, it's not clear whether or not directionality has as much of a difference as it does on EZ brightness, which is not being measured, for example, in this situation. The other thing with STDs is they obviously have generally a much less height, to them and overall volume compared to drusen. And so the directional effect on retinal tissue, at least in my experience, is likely less, but it's something to look at. When we look at future clinical trials, again, I think it's interesting because as we narrow down our inclusion and exclusion criteria, trials become harder and harder to enroll. So I think one of the keys with it is really understanding and ideally having a reading center assessment of the presence or absence, not necessarily for inclusion or exclusion, but to hopefully understand if there's any difference in therapeutic effect, because that's something that really hasn't been looked at extensively to this point. And as we have more and more therapies, it may become more and more important because when we look at some of the phenotypic differences, there may be different pathways involved.
Thank you, Justice. We need to move on. I would like to introduce Ursula Schmidt-Erfurt. I'm going to talk about accuracy and reliability of AI-based assessment of easy loss and thinning in GA. Take it away, Ursula. Thank you.
Hello, my task for today is accuracy and reliability of AI-based assessment of ellipsoid zone loss and thinning in geographic atrophy. These are my disclosures. AI-powered OCT-based segmentation in geographic atrophy focuses primarily on the EZ layer, measuring thickness and consecutive thinning, as well as complete loss. Partial EZ loss can be defined as a loss of below 20 microns, and the EZ layer, as well as the partial loss, and complete EZ loss and RPE loss, can then be displayed in an en face manner in a relatively precise way. The precision is obviously based on an accurate identification of the inner and outer boundaries. This process works quite well already and is used by multiple groups. However, there is, particularly in terms of precision, always room for improvement and increased accuracy, and I would like to guide you through 5 steps to improve what is already good. Using a data-driven targeted model enhancement, which includes inspection, the development data, ground truth annotation, model development, and model validation. It is very clear that clinical trial data do not cover the full range of potential patients, and validation may be biased. Our insights derived primarily from 45,000 OCT volumes coming from 8 longitudinal studies, such as the Philly study shown here, and its criteria, which are very precise in terms of the conditions of the lesion. However, real-world data are arbitrary in size and particularly in image quality. The development data matter very much, and we performed a targeted enrichment to develop data, to the development data from 200 cases with 50 real-world cases that are labeled as challenging because the lesions there are either very small or very large. Lesions come from intermediate AMD preceding GA and iRORA, or the presence of fluid in neovascular AMD, or even healthy eyes. You can see the distribution on the right columns. Quality of data is thereby more important than quantity, and particularly the enrichment with problematic cases, which is not a regular medium-sized GA lesion, matters a lot. Next step, ground truth annotation. Ground truth annotation requires a detailed annotation protocol with precise definitions and consistency in annotations. A refined annotation protocol for RPE loss and EZ layers, including intermediate AMD and GA, was used and shows the deviations and the features that appear very often. A detailed annotation protocol is needed for total RPE loss, EZ layer, thinning, and EZ interruptions. And annotations have to be performed under clinical supervision and with continuous discussion of complicated cases. Model development, model optimization is done by targeted improvement in challenging cases, and it includes multiple steps for extended augmentation. Extended image augmentations include contrast changes, noise, rotation, shifting, flipping, bending of the image, and vessel shadows. We have to prevent overfitting to the training data and make the algorithm robust to image artifacts like noise and other image features. Model validation has to provide a good representation of the target populations and offer enough samples for subgroup analysis. We used a validation data set out of 43 eyes of 43 patients randomly selected from 1,000 visit and stratified for RPE loss area, which is GA lesion, and drusen size. This allowed us to obtain a robust and precise biomarker measurement, particularly focusing on EZ thickness and not only EZ and RPE loss. Fully automated and reliable segmentations have to be resistant to pseudodrusen presence, drusen collapsing, drusen noise, all features that occur very often in AMD and particularly in GA lesions. Model evaluation is shown here. So we obviously found a high correlation between human and algorithm measurements at a level of 0.995. The absolute mean difference of RPE lesion size was 0.5 square millimeters only, which is significantly below what is seen in autofluorescence. The EZ thickness absolute error was particularly small, 1.57 microns, which is less than 1 pixel. This is why we refer to this accuracy as subpixel accuracy. Why would that matter? It would matter because GA is an irreversible disease, so screening and finding early lesions is key. We could show earlier that ONL and EZ thinning precede conversion to GA for a long time, mostly more than 12 months. And this thinning is very subtle in the beginning. We could also see that baseline EZ was primarily thinner in eyes that develop very early lesions, as shown in a Pinnacle study following more than 400 intermediate AMD patients all throughout conversion, which was mostly triggered by EZ thinning. Functional monitoring is most relevant in AMD and particularly in geographic atrophy, and it is again tightly bound to the condition of the EZ thinning that converts to EZ loss. And we could show that there is a tight one-to-one correlation between the decrease of EZ thickness and the decrease of retinal sensitivity, and that a decreased EZ thickness leads to higher transition probability to EZ and RPE loss, which can be as high as 28% over a year. In conclusion, a highly accurate and precise measurement was performed even in small lesions, which allows reliable detection and measurement of new lesions. We obtained a demonstrable improved robustness against noise, expanding the range of scans that can be processed. Integrated uncertainty analysis is important to identify issues with scan quality, supporting early-stage disease monitoring. Thank you so much for your interest.
Thank you, Ursula. That was super. I know Amita had a question here. So, Amita, go ahead.
Yeah, thank you, Ursula. That was a great process of the AI model validation. My question is, in many of these cases, examples that you showed, the EZ loss tends to expand beyond the 6 by 6 millimeter square of the OCT on FOSS. And when it expands, you reach a ceiling effect because it's an artifactual plateauing of EZ change. How do you deal with that? Do you remove that data from analysis or training?
And we do both. So obviously, if any type of lesion in imaging is too large, it will extend beyond the borders, and that causes a ceiling effect. This is why we suggest to use in clinical trials lesions that are not as large as the ones that were selected now in the beginning, where the lesion sizes were rather small already at the level of the RPE loss. And we know that the EZ loss extends by far what is seen in terms of RPE loss, particularly in the lesions of interest, which have a high EZ RPE loss ratio and a much higher progression rate. So indeed, this is why lesions should be kept fairly inside the field of measurement, and you can do a calculation based on what the natural progression is to make sure that in clinical trials, those lesions are selected that will be within these limits all the time. That would be the ideal situation.
I have another question. It's for also Justice, if you can have a remark. So you show this augmentation process clearing the noise around the scan. So how does it actually affect the fact that we're actually intervening in the data itself for the training of the algorithm eventually? If you can remark on that, Justice, maybe you after.
So there is training and development of an algorithm. And we have learned by doing a lot of analysis of different trials, not just the OAKS trial that was shown all over, but there are other substances, and it has become very clear that the EZ layer integrity or deletion is the leading parameter for progression and for disease activity. And it's not just EZ loss. There's a particular focus on EZ thinning, as I mentioned at the end of my presentation. So EZ thinning does not only correlate to function one-to-one, but it is also indicating from the start which eyes will progress either to conversion to GA if you start with intermediate AMD, or which GA lesions will grow further and which will be the fast progressors. So obtaining an algorithm by all the steps that I showed to you, which are the steps that we selected, there may be others as well, but this led to a very high accuracy of EZ thinning measurement, and we believe that EZ thinning is key.
Thank you. We need to move on. Thank you, Ursula. That was great. So
Thank
our
you
next
for the
speaker,
questions.
Barbara Blody, we're going to speak about the use of an AI algorithm by retina specialists in pre-screening GA patients for possible trial enrollment. Thank you, Barb.
Good morning. I'm Barb Blody from the University of Wisconsin, and I would like to share with you our work on the use of AI for evaluation of retinal imaging. Specifically, I'm going to focus on AI-assisted pre-screening for geographic atrophy. I have no financial disclosures. We all know that in geographic atrophy clinical trials, there's a standard practice for screening patients. There's the inclusion size criteria, the physician screening, and the reading center confirmation. And because it's difficult to assess GA area, we see a screen failure rate of 50 to 60%. We also know that many groups have developed AI models, and they've been successful in measuring area of GA. But the use of autonomous AI in the clinic requires FDA clearance. Our question is, how can we use these AI models and implement them for research and clinical trials? Our goals are to assess the potential of AI with clinician review to reduce the rate of screen failure in the clinic. And we'd like to compare the accuracy of AI to traditional reading center workflows. The University of Wisconsin does have a GA pre-screening tool. The model development is explained in these two papers from 2024. Today I'm going to focus on AI-assisted pre-screening deployment. How can we implement pre-screening? In this case, we are conducting an imaging trial. This is a single site study, a prospective trial comparing FAF imaging systems. In this trial, we do have specific size criteria that's a bit broader than most clinical trials and includes multifocal lesions. Here's the workflow for the AI-assisted pre-screening. The retina specialist examines the patient and determines whether the patient is potentially eligible, as we would normally do. Autofluorescence imaging is obtained, and those autofluorescence images are uploaded to AI platform, and a report is available in real time. Images are also submitted to the reading center for manual grading. So here's that report in much larger, and in this case, the clinician reviews the mask on the left and agrees with the AI mask and agrees that the area is within eligibility criteria. Sends this image to the reading center, also agreement by manual grading, and the patient is enrolled in the study. Here's a different situation where the autofluorescence shows a very small, the AI mask shows a small area of hypoautofluorescence, and the clinician agrees with that AI mask. And in this case, the area does not meet the eligibility criteria, so these images are not sent to the reading center. And this is a third situation where the AI mask is shown on the left, that the clinician feels this is inaccurate and disagrees with the AI mask. This then is reviewed by the reading center, and the area is larger at 1.25, which does make, in this case, does make the patient eligible for the trial, and the patient is enrolled. So AI pre-screening agreement with reading center was very close. It was 87% accuracy, and you can see that applies both to those smaller lesions, but also to very large lesions. We see pre-screening errors with AI. AI is not perfect. You can see on the left that here the AI has overcalled GA. The peripapillary area atrophy is included in the area measurement. This still remains within our inclusion criteria. And on the right, the opposite occurred. The AI missed autofluorescence, hypoautofluorescence, and GA, also still within the inclusion criteria. But you can see that AI might make a difference by undercalling or overcalling for inclusion. Let me share with you our results. Here we have the numbers for that pre-screening workflow. 107 eyes were evaluated, AI pre-screen done for each of those eyes. Of those eyes, 91 went on to be reviewed by the reading center because the clinician reviewed the image and said this patient's eligible or could be very close. And the reading center would either confirm as eligible, 63%, or ineligible. But what's different here are the ineligibles found in the clinic. So this is the value of pre-screening. The ineligibles were 15% of the total. The traditional reading center workflow with no AI, images go straight to the reading center. Here there was a high rate of eligible, 64%, but ineligibles were at 36%. So let me show you the comparison of the two. The traditional workflow screen failure rate, 36%, that's reading center only, compared to the AI-assisted pre-screening in the clinic, so 22%. So this did show us that there can be some improvement in the screening of patients if we can use an AI-assisted pre-screening. The reasons for ineligibility was GA area outside the allowable range, poor image quality, or confounders. And here's a few confounders to show you. Neovascular AMD with atrophy was one, peripapillary atrophy, as you see in the middle, and other pathology, which I think often was consistent with inherited retinal disease. In summary, the AI-assisted pre-screening with retina special oversight can lead to improvement in clinical trial enrollment. It provides real-time feedback for clinicians, reduces imaging burden on the patient, reduces costs, and streamlines the patient selection for clinical trials. I'd like to thank my colleagues at the Wisconsin Reading Center and AI unit as well as colleagues in the Department of Ophthalmology and Visual Science who helped recruit these patients. Thank you very much and look forward to your questions.
Thank you, Bob. I think that's great. I think we all agree that AI is the next step for pre-screening. I have one question. So I guess in the reading center they also use an algorithm. Isn't it the same algorithm that you use for the pre-screening or a different one?
It is the same, excuse me, but there's manual oversight. So the grader is always reviewing. So it's really that, I'm sorry, and in this case, it was only the grader. Sorry. In this case,
It's not,
that was the manual only. So
I get it.
that we could have a comparison, a clean-cut comparison of human grader versus the AI system. Yeah. So,
Barbara, if I may ask a question.
yeah,
Sure.
In what type of GA lesions is there most likely to be disagreement between manual and AI grading?
in what type?
Yes.
Yeah, that's a great question. We found a range, Jackie, and because there are 107 eyes, I don't think we can say with accuracy what is the biggest cause of disagreement. That's something we want to investigate further. Good question.
And did you lose patients because of the pre-screening? Like
Yes.
patients who would not.
So it was pretty high. That the investigators did pretty well, finding those who seemed eligible or very close to eligible. But there was 16 eyes, and that was about 15%, that were eliminated at the clinic because both the clinician and the clinician reviewing the AI saw this patient is not going to make it. Too big or too small. So that was helpful. And I think for all of us, I never know what the area of the GA is when I'm looking at the patient. So it would be great if the retina specialist has some input, some information in order to help make a decision, which would save time for everyone.
For sure.
And the clinical site, the research unit, everyone.
Stefan, you got a
Extremely
question?
Yeah, Phil, go ahead.
Stefan, oh, you're muted.
Yeah. So is the feature also looking at other markers like diagnosis of AMD dystrophies or foveal sparing?
No, but we'd love to get to that point. So this is really our first pass. It took some time to get approval from our IRB. This is only on research patients. It's not yet implemented in the clinic, but it would be great to have other indications.
Great. Thank you. Thank you, Bob. We need to move on. So our next speaker, David Eichenbaum, we're going to speak about the proof of concept study for candidate identification in GA, potential for enrollment efficiency and enrichment using an AI-driven workflow. Go ahead, David.
I'm David Eichenbaum from Retina Vitreous Associates of Florida, and I'm grateful to Angiogenesis for inviting me to present a proof of concept study for candidate identification and geographic atrophy, potential for enrollment efficiency and enrichment using an AI-driven workflow in collaboration with Retina AI. These are my financial disclosures of note. I'm an investigator and a consultant for Retina AI. This paper shows the top reasons for screen failures. Looking at 87 retina trials and almost 1,000 patients, about half the patients screen failed and over 44% of them screen failed because of imaging criteria. That's the biggest reason for screen failures in clinical trials. The proof of concept study objectives for candidate identification was constructed here to see if we could determine if it was feasible to use an AI-driven workflow, both AI imaging analysis and EMR review to find qualified candidates, driving with images first. And in doing this, we want to compare this list of historical data to evaluate enrollment efficiency and enrichment of the screening candidate. We used a retrospective analysis framework for this study. We analyzed data from our own site during the enrollment periods for Gather 1 and Gather 2. Retina AI discovery technology was used to automatically upload, anonymize, and process the OCT imaging data using AI models for layer, fluid, and biomarker segmentation. Next, the data was filtered by GA lesion inclusion and exclusion criteria to generate a list for EMR reconciliation, and that list was cross-referenced with clinical inclusion and exclusion criteria, including ICD-10 confirmed diagnosis. We then compared this qualified list against the historical data for screening and enrollment in Gather 1 and Gather 2. As part of the methodology, we identified these windows of time to evaluate unique patients and newly added patients. Within the retrospective time frame, data from patients visiting the office during the 6 months prior to G1 and G2 enrollment was evaluated using an AI-driven workflow, AI-based imaging, and EMR review. The same AI-driven workflow for screening candidates was used to evaluate newly added patients in each prospective 3-month window through the Gather1 and Gather2 enrollment period. This slide shows the lesion characteristics that we loaded into the system. G1 and G2 lesion inclusion and exclusion criteria were taken directly from the protocol. And on the right side, you see the AI-based biomarker criteria that were listed. These imaging-based criteria were applied as filters to the dataset after filtering for age and imaging quality criteria. Retina AI's discovery technology for the AI imaging analysis workflow was used to drive the imaging portion. First, Discovery Connect, an executable file at the site level, automatically anonymized and uploaded the imaging data during the G1 and G2 enrollment period. Next, OCT imaging data was processed with Retina AI's models for layer fluid and biomarker segmentation and quantification. Finally, the search engine within the Discovery platform can be used to set the lesion criteria to generate the list of pre-qualified candidates before EMR review. We had two objectives for this retrospective analysis study. One was enrollment efficiency. Can an AI-driven workflow improve enrollment efficiency compared to historical results? The other objective was related to candidate enrichment. Those who were historically screened, would they have passed qualification using the AI-driven workflow? During the Gather1 and Gather2 enrollment period at our site, we screened 26 patients, had 20 screen failures, and enrolled 6 patients. 90% of our screen failures were due to not meeting imaging criteria, consistent with what we saw in the published evidence for screen failures. During the Gather1 and Gather2 analysis timeframe, 10,421 unique patients were analyzed. 89% of this pool was excluded because of incorrect RPE defect and/or fluid presence. Of these patients, 7% were excluded because of central involvement of their lesion, and a final 155 patients, or 1%, were excluded because the GA lesion was absent in the 3 mm region. This left us 270 patients meeting GA lesion criteria by imaging following AI-based imaging analysis first. We then analyzed the patients based on EMR reconciliation. In the G1 and G2 enrollment periods, we had 270 unique patients found after AI-based imaging filtration. 47% of these patients were removed because of prior anti-VEGF therapy. 39% were removed because of common diagnosis history. 9% had no EMR data or non-ICD-10 diagnoses for GA, and that left us with 24 patients, or 9% of the starting pool, as qualified candidates for the Gather studies. Another analysis perspective of these 24 candidates is to look at the accumulation of qualified candidates in each analysis time window. For the 6 months prior to enrollment, here are the patients who were identified based on AI-based imaging review. Throughout the enrollment period, you can see the additional candidates identified, equating to around 1 to 2% of the clinic's pool of total and new patients during that time frame. Following EMR review, you can see the accumulation, the cumulative number of patients yielding 24 patients passing both AI imaging and EMR filtration of the 10,421 patients who underwent analysis. Historically, we did enroll 6 out of 26 patients screened, giving us a 23% efficiency at our site using our traditional methods. Historically, we see this on the left side. 26 patients screened, 20 screen failed, 6 patients enrolled. Using the AI-driven workflow on the right side, 24 qualified patients were found after AI imaging analysis and EMR review. Since these candidates passed both AI lesion criteria and EMR analysis, it's feasible to consider that, barring no other confounding issue or a patient not consenting, the enrollment potential could be 100%, a 4-fold improvement potentially over what was done historically. Now, let's look specifically at the patients who were historically screened and how the AI-driven workflow would have evaluated them. 24 of these 26 patients historically screened had OCT imaging available. Of these 24 patients, and following their screening journey, 5 ultimately enrolled. Taking these same 24 patients analyzed by the AI-driven workflow, we see that 18 of them were excluded after AI-based imaging filtration for GA. An additional 2 were excluded following EMR review. One had Stargardt's and the other had an ERM, and that left us with 4 patients that would have quality stamp of approval for screening visits based on this analysis workflow. Comparing enrollment efficiency, the AI-driven workflow again improves efficiency by 4-fold or so over the historical result. Following cases are proof of concept for this study. For this patient, the AI-driven workflow included the subject, and historically the patient was enrolled. For this patient, the AI-driven workflow excluded the subject, and historically this patient was a screen fail. This patient was included in the AI-driven workflow, but was not selected for screening. We missed this patient at the site level because in the EMR notes on the right, we see that this patient was actually interested in clinical trials. In conclusion, we see the potential for efficiency with a potential 4-fold plus increase in this retrospective analysis and enrichment with appropriate selection of 17% of the historical screening pool, and that the AI-driven workflow has the potential to identify highly qualified candidates. Limitations of this study are that it's a retrospective analysis and candidates identified through the AI-driven workflow have not actually been through screening. Next steps are integration of AI-based workflow in a current prospective study and a review of the qualified list by a reading center expert. Thank you for your attention for this presentation.
Thank you, David. I think that most of us agree that that's already here, using AI for pre-screening. My question to you, like practically wise, do you use it in your clinic nowadays? Do you use it like in your clinical trials nowadays? Is it actually efficient, or it's an exercise?
So it's a great question. I think at this stage, it's still an exercise, Omer, because we don't have a prospective trial which has this sort of pro forma in our formal pre-screening. What we need to do is test drive this prospectively. We do have this for large language models using analyses that were initially started by Vestrum, and now Thermo Fisher PPD runs that. But we need to have a true protocol-driven pre-screen with AI reading from any one of the AI providers. This particular analysis, of course, is looking at Retina AI's work, but there's several that are ready to go, and I'd love to see how it works prospectively. And I want to emphasize this is in combination with the technology that Barbara eloquently presented. You do this at the site level, and then you send it in and you confirm it at the reading center level, and theoretically, you could rapidly increase the rate of enrollment and make the efficiency of clinical trials and the speed of drug development exponentially faster.
Great. Thank you, David. Yeah, go ahead, Jackie.
David, do you think reticular pseudodrusen is in any way a confounding factor in the AI assessment?
It's a good question, and that depends on the technology, Jackie. I think that ultimately the best technology would be able to mitigate things like reticular pseudodrusen, and that's why we have to give it a prospective test drive.
Okay, we'll move forward. With Diana Doe, we're going to talk about AI in GA learning from the pegcetacoplan clinical program. Take it away, Diana.
Hi, I'm Dr. Diana Doe, and on behalf of my co-investigators, it's my pleasure to share information about artificial intelligence and how it can be used to evaluate geographic atrophy across registrational studies and into clinical practice. My disclosures are noted here. I also serve as a consultant to Apellis. In neovascular AMD, OCT is an established tool to monitor disease progression and treatment. However, in geographic atrophy, which is a chronic, progressive, irreversible neurodegenerative condition, the utility of OCT is not yet clear. In GA, it's clearly more challenging to use the OCT in clinical practice. In this example, the retinal thickness stays relatively the same, but yet there is progression of geographic atrophy nasal to the fovea. What about artificial intelligence? The utility of AI to follow and treat patients with GA has been an area of focus in research, with a number of studies demonstrating its potential in the field of GA. For this presentation today, I have 2 objectives. First, I'm going to present AI-driven insights on pegcetacoplan for the treatment of geographic atrophy. Second, I'm going to introduce a new and practical tool for managing GA patients in the clinic. We understand that GA is a neurodegenerative condition, but yet it's heterogeneous, and patients may present at different points along the continuum, early, progressive, or late in the course of the disease. First, let's focus on each stage of GA, starting with early geographic atrophy. AI analysis were performed on the Phase 2 FILLY dataset. Recall that in the FILLY study, after 12 months of treatment with pegcetacoplan, monthly administration reduced GA growth by 29%, and every other month pegcetacoplan reduced it by 20%. The average effect of pegcetacoplan across the entire GA lesion is approximately 29%. But where is it the most effective? An analysis from the Vienna group investigated this, leveraging AI-generated segmentation, slowly analyzing the OCT images from the FILLY dataset. They found that the treatment effect is not uniform around the lesion. In fact, in the region 0.5 to 1.5 millimeters from the fovea, the reduction in GA growth is 33% and 21%, with monthly and every other month pegcetacoplan compared to sham. When we get right up to within 0.5 millimeters of the fovea, pegcetacoplan's effect is strongest where it matters most, with monthly dosing notably slowing inward growth to the fovea by 44%. Far more than the overall average. Another AI analysis also found that the benefit is actually even broader and extends to the photoreceptors beyond the GA border. Shown here in this figure, pegcetacoplan treatment led to a meaningful reduction in the EZ loss 1 millimeter from the GA border. Even farther out at 1.5 millimeter from the lesion, a similar effect was seen in the outer nuclear layer, which contains the photoreceptor cell bodies. And pegcetacoplan's effect extends even beyond that, across the entire 6 by 6 millimeter OCT field, highlighting that pegcetacoplan's neuroprotective effect in GA extends well beyond the lesion border. Now let's move on to progressive geographic atrophy, where treatment is clearly an option. Using AI, we learned that, and this has been shown in previous studies, pegcetacoplan leads to reduction of approximately 50% in EZ loss compared to sham, and this is achieved very early after starting the treatment. AI has also helped us learn that EZ loss precedes RPE loss, as you can see here in the video. The EZ loss is represented by the green areas, and only afterwards is it followed by loss of RPE, represented by the orange. This is different than what we initially thought about GA disease. Another related finding is that the relationship between EZ loss and RPE loss matters, and it can be predictive of disease activity. In this figure, we developed AI quartile analysis of sham eyes from the Oaks and Derby studies showing the natural history of disease progression. When the difference between EZ loss and RPE loss is the largest, represented by the light blue quartile 4 line, it's correlated with much faster GA lesion growth. When this EZ-RPE loss ratio is closer to 1, representing slower growth, like the gray quartile 1 line, GA grows much more slowly. It's not just the natural history data where the EZ-RPE ratio is important. In the Oaks and Derby, eyes with lesions in the highest EZ-RPE quartiles not only progressed faster, but they also responded best to pegcetacoplan. This insight can guide us in selecting the right patients for treatment if we have the right tools at our disposal in clinic. We've learned in recent years that the fellow eye can also be very clinically relevant measure of progression. In these side-by-side videos, the one on the right with the eye treated with pegcetacoplan shows less EZ and RPE loss, and the fovea stays protected longer, compared to the untreated fellow eye, which is on screen left. Another AI analysis from the Oaks and Derby study further confirms this pattern. While GA growth was highly consistent between sham eyes and their untreated fellow eyes, both pegcetacoplan monthly and every other month significantly reduced EZ loss compared to the untreated fellow eyes. This data reinforces the importance of analysis of fellow eyes with GA as a potential comparator and as validation in open-label extension studies. Finally, let's talk about more mature GA lesions, which are late GA. GALE is an extension study of Oaks and Derby. Patients on sham treatment for 2 years were switched to pegcetacoplan, and these lesions were more advanced and large, approximately 12 millimeters squared. AI shows that it's actually not too late. After crossover to active pegcetacoplan, the sham eyes had their photoreceptor degeneration flatten and essentially halted over those first 6 months on treatment. All of this data is very interesting research-wise, but what about the clinical utility for patients with GA? A potential tool called functional OCT is currently being developed. Trained on OCT and microperimetry data, it estimates retinal sensitivity across the macula using the OCT device you already have in clinic, with no extra equipment needed. It can provide sensitivity maps, which are similar to thickness maps, but we can use this to track functional loss of retinal sensitivity over time. To summarize, in early GA, pegcetacoplan slows growth towards and beyond the fovea. In progressive GA, the EZ-RPE loss ratio helps to identify patients for closer follow-up and treatment. And finally, even in late GA large lesions, pegcetacoplan can preserve the EZ even though the treatment is started later. We hope to have functional OCT available in the near future, and thank you very much for allowing me to share this information.
Thank you, Diana. That was super interesting. I have one question also related to what Carl showed us. So you saw more protection of the fovea region. So do you think there is any difference on protection between cones and rods based on what you have shown us? Either like any more data considered to that?
Yes, I think there is now a bigger body of evidence suggesting that complement inhibitors do protect progression of the GA growth towards the fovea, and that treating lesions before they grow into the fovea is very important. Of course, for clinicians, we need tools to encourage our patients to follow up and be adherent to treatment. And perhaps functional OCT, when it becomes available, can help both the retina specialist and the patient understand the disease better.
So does it mean when the patient arrives to you, you suggest the eye with the non-foveal involvement to start treatment first? Question.
Yes, sometimes, you see a patient, one eye already has lost vision to central geographic atrophy. The second eye still has good vision, and that patient is motivated to preserve their only good eye. And so that's why those patients would benefit from earlier treatment.
Diana, how do you take this artificial intelligence finding and apply your human intelligence in deciding who to treat and who not to treat?
I think it's an art. So AI will assist the retina specialists, especially the busy retina specialist who's seen a lot of patients in clinic. But ultimately, it's a discussion of the benefits and risks that need to be done with the individual patient, and the physician will need to do that.
But are you looking at OCT and the outer retinal bands and deciding who's a likely candidate and who isn't?
Yes, I am, because sometimes we see that the OCT shows us the loss of the EZ line, or that it's very at risk of becoming involved. And that can give us more information than just the fundus autofluorescence.
Thank you.
Thank you. We need to move on. So our next speaker, Stefan Schmitz-Walkenberg, we're going to speak about the AI-powered prediction of retinal function by OCT imaging in GA. Take it away, Stefan, our last talk.
Hello, my name is Steffen Fritz-Falkenberg, and on behalf of the Oaks and Derby investigators, I would like to present AI-powered prediction of retinal function by OCT imaging in geographic atrophy. These are my disclosures. For the current presentation, I would like to report contracts with Apellis. Most well-established functional tests, such as best-corrected visual acuity, show only little correlation with GA manifestation and lesion growth, as demonstrated by CHROMA and SPECTRI, two independent phase 3 studies within large GA cohorts. It remains an unmet need to identify functional measures that are able to track GA progression more effectively. Microperimetry appears particularly promising to effectively bridge structure and function. Of note, in CHROMA and SPECTRI, microperimetry was the only functional test that correlated with GA growth. However, microperimetry has several well-known limitations. These include limited access and lengthy testing time for patients with poor fixation. Importantly, even when testing with an extensive and time-consuming 68-point grid represents in reality a sparse pattern, as it obviously can miss functional changes in between measurement points. Considering the typical rate of GA progression with a growth of about 100 to 300 microns per year, it becomes evident that it would take approximately 2 years for GA to spread from one to the next neighboring test point. These limitations of microperimetry can also be potentially seen from the data of the pegcetacoplan clinical trials. Both Oaks and Gale trials used microperimetry to assess change from baseline in new scotometers points in pegcetacoplan-treated arms versus sham. As shown in this graph from Oaks, a signal of favoring functional benefits in treated eyes was just starting to emerge between years 1 and 2. Overall, it took until year 3 for this signal to reach significance, suggesting that the retinal tissue being preserved with pegcetacoplan is in fact functional tissue. Previously, our group introduced a novel and innovative solution, inferred sensitivity. Using artificial intelligence, volumetric OCT and microperimetry data is trained and then used to estimate retinal sensitivity at each en face pixel, as shown here on the right. This yields a high-definition sensitivity map similar to an OCT thickness map. Similar models have been developed to infer retinal sensitivity for other retinal diseases, including Stargardt disease, neovascular AMD, and central serous chorioretinopathy. This approach has now been further developed into a tool called Functional OCT or OCTF in partnership with Apellis and using the imaging and extensive microperimetry data from both sham and treated eyes in the pegcetacoplan studies. OCTF offers a high-definition sensitivity map that overcomes microperimetry grid limitations by using structural volumetric OCT data. The tool allows, after rapid acquisition of a conventional OCT scan, so without requiring a separate microperimetry device, to quickly predict retinal sensitivity across the macula in eyes with geographic atrophy. For the development, AI was first trained on untreated fellow eyes from Oaks, then tested on the full Oaks dataset and on Derby. For Derby, microperimetry data wasn't included, so the model provided functional insights even when functional testing wasn't used. Training used layer thicknesses and intensities derived through the Great Reading Center segmentation algorithm, spatially correlating to the decibel values at each microperimetry point. Evaluating the model performance, that is, comparing the estimated sensitivities by the model to the actual obtained microperimetry sensitivity values as tested, a high correlation with through sensitivities and with a mean absolute error of 4 decibels was seen. On the right side of the slide, the feature importance is displayed. This overall underscores the biological plausibility of the model, as different photoreceptor OCT bands are the most important factors for retinal sensitivity, while RPE drusen complex and choroid contribute much less to the model. The mean absolute error of 4 decibels seen with OCTF, as shown previously, is very much comparable with similar errors that have been reported for inferred sensitivity models in other retinal diseases. Of note, and this is shown far on the right, the errors of inferred sensitivity are also in the range of the test-retest variability of microperimetry testing itself. OCTF has been further validated externally, that is outside any pegcetacoplan studies, using real OCT and microperimetry data from 39 patients in the directional spread on geographic atrophy natural history study that had been performed at the University of Bonn, Germany. The OCT model that was trained on Oak's fellow eye data showed strong performance when comparing actual tested and inferred sensitivity values, with a strong significant correlation and an error of around 4 decibels. This slide illustrates the power of OCTF. It shows the predicted sensitivity maps of a sham patients in Derby, the pegcetacoplan study that had not included any actual microperimetry testing. It shows the absolute scotoma progressing from baseline to month 24, with surrounding reduced sensitivity highlighted in red just next to atrophy and more far away in orange. Applying OCTF to data from the pegcetacoplan clinical trial program, the phase 2 FILLY data shows significant retinal sensitivity preservation, with a difference to sham of 40% and 34% in the monthly and every other month treated group respectively. Similarly, applying OCTF to pooled phase 3 Oaks and Derby data reveals a statistically significant difference versus sham and retinal sensitivity loss at 24 months. Due to the original microperimetry grid sparsity, it is plausible that this effect was previously undetectable until year 3, with notable implications for the 2-year clinical trial data. We know from the clinical trials that pegcetacoplan was more effective in non-subfoveal lesions in Oaks and Derby. Similar effects are shown for OCTF. The difference to sham in preservation of retinal sensitivity in subfoveal lesions, with 44% and 36% in every month and every other month treated eyes, is pronounced, but overall less when compared to non-subfoveal lesions. When looking at the group with non-subfoveal lesions, here on the right, the preservation is in direct comparison even more pronounced, with 53 and 39%. Finally, looking at the Gale data, we can see preservation of retinal sensitivity over the long term, with significant differences to fellow eyes after 4 years of treatment. To summarize, OCTF is an innovative AI method that correlates structure and function using just structural OCT, eliminating the need for microperimetry testing. The technology demonstrated sensitivity preservation in Oaks at 24 months as well as in Derby even without microperimetry data. This approach could potentially transform patient assessment and serve as a functional outcome metric in future geographic atrophy trials.
Thank you, Stefan. That's fascinating. 2 questions. First of all, do you think the regulatory authorities eventually will accept this tool as an endpoint, as a functional endpoint, because actually no function was really measured? Second, can we use that tool in order to predict, because of all the correlation that we have backwards, do you think eventually we can use functional OCT to predict GA growth?
Yeah, so thank you very much. So first of all, from a regulatory perspective, I don't think that this model trained here can be accepted by regulatories for other interventions. So you would need to do at least a subset of patients would at least need to have microperimetry data because you don't know if your intervention interferes with the OCT signal. So you would need first show that it does not. And through predicting function in the future, I think this is kind of the next step, and this needs to be evaluated. So I don't know really.
Hey, Carl, your hand was up next.
Oh, yes. So, Stefan, great talk. I'm curious. So, you showed less than 1 dB differences. So tell me, what is the implication for visual function, right? So if you preserve 1 dB of retinal sensitivity, how do you translate that into a true benefit to the patient?
Yeah, that's kind of the next question, if it's not only statistical significant and also clinical meaningful. And this needs to be also evaluated in the future. But it's in fact
the first sign of a functional effect very, very short at the start of treatment. Yeah, that's something that needs to be evaluated. You also mentioned in your talk about quality of life. Obviously, this is not reflected by OCTF alone.
Okay, Vas, quick question.
Yes. Yeah.
Yeah, thanks very much. Great presentation, Stefan. Omer asked a question before about functional correlation with some of these different layers, and I just noticed in your presentation that it seemed that the inner segments and the outer nuclear layer correlated the best in terms of, or the most predictive in terms of the microperimetric sensitivity. Do you think that these kinds of tests could be used as a validation of what the best layers are for our selection as endpoints?
Yeah, definitely. It adds to the whole picture. And I'm very grateful about your talk and also Giovanni's talk, emphasizing that EZ is not everything. EZ is important, but measuring the ONL, as shown by Giovanni, has some big advantages. So I think at the end of the day, it's kind of a cocktail of different OCT markers we need to use to assess progression, function, etc.
All right.
Thank you. We need to conclude. So I would like to thank our session two speakers and panelists, and to my co-moderators, Jackie Kovacs and Phil Rosenfeld. Don't forget to visit the virtual exhibit. Just click the exhibit link in the meeting site. And if you haven't done the pretest, please do so. Please send your questions in the chat panel. And also, please stay us for the next session number C, entitled GA in AMD. Thank you.